Well, hello. This week we're going to skim through infections of children and adolescents. Some of it, in a few cases, is probably going to reflect illnesses that can show up as adults. Okay. And this depends on certain factors like did they get it and has it lie dormant, etc. So this is week 4, infections of children and adolescents. So let's go forward. Now, in this process, I'm going to try to take general coverage of all infectious diseases listed. So you'll get the name of the disease, the pathogen, the type of organism, the structure or presence of a toxin, and if they have an endospore, respiration or metabolism, etc., where it's available. Locations of the pathogen or any reservoirs will be mentioned. Symptoms, signs. Now remember that a sign is an objective and externally observable. Symptoms are a person's reported subjective experiences. So what we're going to try to do is cover these and as it relates to the illness, injury, or condition. We will also try to mention, or I will try to mention, if there are any antitoxins, antibiotics, antifungals, antihelmintics, or antiprotozoal drugs, and whether or not there is, a vaccine and what is the time length of an effect. So let's start off first with diphtheria. And this is a serious infection that's caused by strains of bacteria called Corynebacterium diphtheriae. Now, this particular bacteria makes a toxin, and it can lead to difficulty in breathing, heart rhythm problems, and even death. Now, C. diphtheria is a non-encapsulated, non-motile, gram-positive bacillus. Diphtheria is caught by coming into contact with droplets from a respiratory tract of an infected person, particularly spread by coughing or sneezing. If the disease is cutaneous, it can be spread by coming into contact with the wounds or lesions of an infected person. A serious infection of the nose and throat, and it's interesting, this is all preventable by a vaccine. Now, this situation with the nose and throat, you end up forming what is called a pseudomembrane. As the infection grows, you're going to get a thick gray matter sheet, and it kind of covers the back throat. It may also cover things like some of the tonsils, etc. Symptoms include sore throat, fever, lymph nodes, and weakness. The recommended antibiotics for respiratory or cutaneous diphtheria are either erythromycin or penicillin, but you also have to consider that you have an toxin that's been released by the diphtheria bacteria. So you have to have an antitoxin that neutralizes the diphtheria toxin. CDC recommends that vaccines for infants, children, teens, and adults to prevent diphtheria. Also, as I mentioned before, that treatments include antibiotics and an antitoxin, that will neutralize the diphtheria toxin. So the vaccine is very much present. And if you see here, that blob in the back there is actually the pseudomembrane. And it can be caused, most often you're going to hear it by Corynebacterium diphtheria. It does once in a while show up, caused by the Corynebacterium ulcerans. If you're exposed, incubation is about 2 to 3 days. Symptoms most commonly occur as a membranous nasopharyngitis or obstructive laryngotracheitis. So you have extensive cervical lymphadenitis is seen. You have also life-threatening manifestations, which will include airway obstruction, myocarditis, cranial and peripheral neuropathies. It's rarely cutaneous, vaginal, conjunctival, or optic, meaning basically those are the rare cases coming in contact with the droplets. Here you have a situation where it was cutaneous. Now, the transmission is via respiratory tract droplets, like I said, but you can also get it by direct contact with skin lesions. And what you see down here are the bacterium. They're all gram-positive. Excuse me. Now, herd immunity has almost virtually eradicated this disease. There's one case that's been reported since 2003. Unfortunately, it was reported in 2012 later. And as I've said before, that the treatment is using an antitoxin and either penicillin or erythromycin. And so we move from there to tetanus. Now, tetanus is an infection caused by bacteria called Clostridium tetani. Now, Clostridium, you have to understand, does have endospores. So you can find them in the soil. Now, when the bacteria enter the body, they produce a toxin that is causing painful muscle contractions. That's the tetanospasm. That's why this disease had the other name. 200 years ago, you would be commonly referring it to as lockjaw. It causes the person's neck and jaw muscles to lock and makes it harder to open the mouth or swallow. And it's interesting that the bacteria can survive in a dormant state in soil and animal feces. Now, symptoms include jaw cramping, sudden involuntary muscle spasms, often in the stomach, painful muscle stiffness all over the body, trouble swallowing, seizures, such as jerking or staring, headache, fever and sweating, and changes in blood pressure and heart rate. What happens is as the bacteria grow and divide, you see a release of a toxin called tetanospasm. The toxin impairs the nerves in the body that control muscles. The treatment is metronidazole, and it's 500 milligrams intravenously, IV, every 6 to 8 hours. And this is the preferred treatment for tetanus. But penicillin G, 2 to 4 million units IV every 4 to 6 hours, is a safe and effective alternative for a period of 7 to 10 days. Now, again, a vaccine exists. The booster for the vaccine is required every 10 years. Also, if someone has the disorder, an immediate treatment with the antibiotics, what they also include is a human tetanus immunoglobulin. The greatest risk factor for tetanus infection is not being vaccinated and not keeping up with the 10-year booster shots. I recall CDC documents that basically would show the incidence of tetanus showing up as individuals get older and older, and that's because they haven't been keeping up with their shots. Now, there was Sir Charles Bells who made a portrait of a soldier dying of tetanus. Okay, what you have to understand is this: both the inhibitory nerves and the nerves that would stimulate particular muscles fire at the same time, so it's sort of a what they call a rhesus sardonicus. This characteristic rigidity of the body. Now, this individual was in a battle, and if you knew what occurred in the European continent for the 1800s, there was a lot of wars, and of course people would ride horses and they would go into battle, and of course the grounds were available for the Clostridium tetani, and of course, whatever horse poop was there. This led individuals who were injured, who got a deep penetrating wound, to be dying of tetanus. Usually, what really stops everything, leads to the death, is that the diaphragm becomes rigid. Okay? And they give another diagram here where you can see this was a foot injury. It went up into the spinal cord, into the CNS. And you have this look of this individual, and that's because all the muscles are being rigid. Same thing down here. Now, we're going to move to pertussis, otherwise known as Bordetella pertussis, commonly called whooping cough. Now, Bordetella pertussis is a gram-negative, aerobic, pathogenic, encapsulated coccobacillus of the genus Bordetella, and is the causative agent of pertussis or whooping cough. B. pertussis can express a flagella-like structure, even if it has been historically categorized as a non-motile bacteria. Now, the Bordetella are small, they're gram-negative, aerobic coccobacilli. The pertussis produces a number of virulence factors, including pertussis toxin, adenylate cyclase toxin, filamentous hemagglutinin, and hemolysin. So basically destroying blood cells, messing up secondary messenger systems, etc. It is a highly infectious bacterial disease involving the respiratory tract. And the symptoms are runny or stuffed up nose, low-grade fever, less than 100.4, mild, occasional cough. Babies do not do this. But there is also apnea, life-threatening pauses in breathing, and cyanosis, the individual starting to turn blue or purple in babies and young children. Besides the cough, which sounds like a whoop, its symptoms include the runny nose, nasal congestion, sneezing. Now, for treatment, you have macrolides such as erythromycin, clarithromycin, and azithromycin. These are the preferred antibiotics for the treatment of pertussis for persons 1 month of age and older. There is also a vaccine available. You can see here, here's the Bordetella bacteria here. Here you have individuals who are struggling to breathe, okay? It is fastidious aerobic gram-negative rod, meaning that it is very picky of its culture medium, etc., if you're going to have to do a swab culture. Humans seem to be the only host of Bordetella pertussis, and transmission is by close contact with aerosolized droplets. The classic disease in older adults, older children and adults, is a cathartic stage, a paroxysmal stage, and then a convalescent stage. So severe disease occurs in infants less than 6 months. They end up with atypical presentation. They end up with gagging, gasping, apnea, and bradycardia. That's a slowing down of the heart. There is no lifelong immunity from infection or immunization. The immunization vaccines were introduced in the 1940s. Now, at 2012, there were over 41,000 cases reported in the United States. This is the highest in 50 years. So what has happened is we've had individuals who have decided for some reason or another not to get the vaccine. And as a result, herd immunity is lost. Okay. Now, if you look here, this is from the World Health Organization, the number of cases, and that's the official coverage, and that's the WHO, UNICEF estimates. When you had the onset of using a deep PP3 coverage. And that's basically diphtheria, tetanus, and pertussis. You start seeing these numbers go down quite significantly. And they stay down to a degree. All right. Now, of course, there are other issues involved. There's the different formulations of the vaccine, DTaP, Tdap, and DTP. Now, if you notice here, though, from the 1920s, you started introducing one vaccine, and you started seeing a slide downward. And then what happened was DTaP came in. Now, DTaP contains the diphtheria toxoid, the tetanus toxoid, and acellular pertussis. So usually what that is basically just some proteins, antigens. And some of these are different reformulations. If you notice, we were having number of cases in certain years up to 250,000. Now what we're having are just smaller amounts. Unfortunately, in the mid-2010s, you started seeing some of this occurring again, having a resurgence. And this may be because of a variety of reasons, including children not getting the vaccinations that they really need. Okay, now we're going to move into Haemophilus influenzae type B. This is not like an influenza virus. It's different. It really, you'll hear the use of a vaccine, HIB. It stands for Haemophilus influenza type B. This is all a type of bacteria. It's gram-stained and microscopic observation of a specimen of H. influenzae. Influenza will show gram-negative Coccobacillus. Now, Haemophilus influenzae diseases is a name for any illness caused by this bacteria. Now, some of these illnesses, like ear infections, are mild, while others, like bloodstream infections, are very serious. Symptoms of pneumonia include fever, chills, cough, shortness of breath, and difficulty breathing, sweating, chest pain, headache, muscle pain or aches, and excessive tiredness. Now, symptoms of bloodstream infections, this is where you get it a little bit more serious. Usually you're going to see fever and chills and excessive tiredness, pain in the belly, nausea with or without vomiting, diarrhea, anxiety, shortness of breath or difficulty breathing, and an altered mental state, in other words, a sense of confusion. A bloodstream infection from H. influenzae can occur with or without pneumonia. When we talk about the symptoms of meningitis, typically this is going to include onset of fever, headache, stiff neck, nausea with or without vomiting, photophobia, that is, the eyes are being much more sensitive to light, and an altered mental state, confusion. So as you can see here, this is a type of bacterial organism that can cause somewhat minor occurrences or some that are very, very profound, and the patient has to be checked on. The treatment, we're talking about antibiotics such as cephalosporin, cefotaxime, and cefuroxime is given. Other infections due to Haemophilus influenzae are also treated with various antibiotics given by mouth. They include amoxicillin clavulanate, azithromycin, and cephalosporins. Now, Haemophilus influenzae type B vaccine, also known as the HIB vaccine, is a vaccine used to prevent Haemophilus influenzae type B infections. In countries that include it as a routine vaccine, rates of severe Hib infections have decreased more than 90%. Now, here's part of if you notice here, this is the bacteria here. And I know some of you might be going, well, you went from, blood to the respiratory, then to because what happens is you can have Haemophilus influenzae cause a type of pneumonia, a type of bacteremia in the blood. They can occur in the lower and upper respiratory, or they can lead to meningitis and inflammation of the meninges. Okay? Also, what's interesting is that the most common causative agent of bacterial meningitis in neonates and children and in an adult, you'll notice that basic Haemophilus or HIB shows up in children and to a degree may be present also in infants. There are some physiological signs that can be used. If the patient is supine with a hip flexed 90 degrees, the knee cannot be fully extended. Okay, and that's Koenig's sign. Neck rigidity is Brudzinski's neck sign, and that's a passive flexion of the neck causes flexion of both legs and thighs. So as he pulls upward here, you see the legs being pulled up. Okay? This has a high predictive value for the bacterial infection. And if you notice this child here, if you're very savvy, it was called the tripod position, assumed by children with epiglottitis, but notice around the lips that look somewhat bluish. Okay? All righty. So now we're going to talk about pneumococcal disease caused by Streptococcus pneumoniae. Streptococcus pneumoniae, or pneumococcus, is a gram-positive spherical bacteria, alpha hemolytic member of the genus Streptococcus. They are usually found in pairs and do not form spores and are non-motile. Now, S. pneumonia bacteria can be found in many people's noses and throats and is spread person to person by coughing, sneezing, or coming into contact with respiratory secretions. S. pneumonia can cause both invasive disease, such as meningitis or the bloodstream infection, and non-invasive, such as just pneumonia. Invasive disease symptoms can be different depending on the type of infection the disease has caused. Pneumococcal pneumonia, their symptoms include fever, cough, chills, shortness of breath, chest pain. Pneumococcal meningitis symptoms include stiff neck, fever, mental confusion, and disorientation, and a visual sensitivity to light. Then we have the pneumococcal bacteremia, an infection in the bloodstream. And this may be similar to the symptoms of pneumonia and meningitis, and may also include joint pain and chills. Then we have sepsis. Here, you're going to have confusion or disorientation, shortness of breath, high heart rate, fever, shivering, or feeling very cold, extreme pain or discomfort, clammy or sweaty skin. These can also lead to complications such as brain damage, hearing loss, limb loss, and death. How do we treat it? Well, pneumococcal pneumonia, if you have one of these organisms, they are susceptible. If they're susceptible to the antibiotics, which is what I should say, they're either susceptible or intermediate. You can treat them with penicillin, 1 million units intravenously every 4 hours. Ampicillin, 1 gram every 6 hours. There's cephalotriaxone, 1 gram every 24 hours. The ease of administration favors the use of cephalotriaxone. Okay? And here you have several different notes here. This is what the bacteria look like here. You can see them over here. A lot of bacteria have differing particular characteristics, which is why I included them in some of the designs here. These have a capsule which helps inhibit antibody binding or being phagocytosis. Let's try it again, excuse me. Phagocytotically brought in by macrophages and neutrophils, okay? Here you see the purulent sputum, and when they look at this, you see the gram stain of the bacteria. When the S. pneumoniae comes into the nasal epithelium, you're going to have, obviously, an infection that's going to build up here through the mucus, transmitted. You will also have shedding, such as the passage of nasal mucus. And then you have invasion. And this can include aspiration for pneumonia. You can have this by bacteremia traveling in the blood and then leading to meningitis. Or it can be a local spread. And the local spread can be, for one example, otitis media. Okay? If you take a look here, complications of pneumococcal pneumonia. Here you have an individual who has endocarditis, in other words, an inflammation of the endocardium. They may end up with purulent pericarditis. And what we're talking about literally is damage, pus, etc. in the endocardial area. Epira, sterile pleural effusion. If they start to see a buildup of fluid that begins to interfere with the capability to breathe, okay? You may see intravascular coagulant therapy, especially with asplenic patients. Now, it's also known as disseminated intravascular coagulopathy, and that is basically DIC, where throughout the entire body, you have areas that start forming their own clots. And of course, in doing this, they reduce the availability of the thrombocytes, the clotting cells, okay, or I should say cell fragments. And so what happens is you have clotting where you don't need it, and then where you do need clotting, instead you begin hemorrhaging. The clots can also travel. In doing so, they can also damage circulation, liver, and kidneys. Okay, and in this case over here, you see also septic arthritis. Now, we're going to go into Neisseria meningitis. Neisseria meningitis is often referred to as Meningiococcus. And the reason is that it is a gram-negative bacterium that can cause meningitis and other forms of meningococcal disease, such as meningococemia, which is a life-threatening sepsis. Neisseria meningitis is often referred to as meningitis meningococcus, and unfortunately I seem to have doubled on that, so sorry about that. The bacterium is referred to as a coccus. It's somewhat rounded, and it's called a diplococcus because what you have are these two spherical, basic round cells, and they tend to form in pairs and occupy. Now, this particular type of bacteria is found in the nose and throat without causing disease. Most people that are exposed to N. meningitis do not become ill. Only a few people develop the illness, which might be associated with genetic, immune, social, societal, and physical factors. Common symptoms of meningococcal meningitis include sudden fever, headache, stiff neck. Other symptoms may include nausea, vomiting, increased sensitivity to light, and confusion. Children and infants that show differing signs and symptoms, such as inactivity and irritability, vomiting, and poor reflexes. Now, meningococcal infections are usually treated with penicillin, ampicillin, or a combination of penicillin and chloramphenicol. And here you can see how we have this. They have sort of a pili off of them, these bacteria, and they get into the nasal cavity. And they go through a process of infection by basically attaching to some of the nasal mucosa, particularly those that have cilia, and altering the charge, and eventually beginning to move into the cells and down through the cells. So it's an aggravation, deaggregation, reattachment, and invasion. Now, part of this is because you have some of the detachment, it's spread to other human hosts. A sneeze, for example, or a cough. If you take a look at here you have meningococcal from blood. You would see the same images if you had that taken from throat or spinal fluid. And you can see the individual here has shock, prostration, cyanosis, extensive purpurea. These are some of the things that occur. You're going to have disseminated intravascular coagulation, like I mentioned to you. That's what some of this looks like. You will have the liberation of interleukin 1. You will have plasma activator inhibitor 1. You will have thrombin activated fibrinolysis inhibitor. Then you have tuberculosis factor alpha. Now, some of these are going to basically help with the proliferation and the spreading of bacteria, but others are going to contribute in various ways to form, as you can see here, the clot. And once that clot's made, okay, you're going to need some of the thrombocytes. And this can happen throughout the body. This is all part of disseminated intravascular coagulation. The next one here is poliomyelitis, the poliovirus that causes the disease polio. It's an infectious viral disease that affects the central nervous system and can cause temporary or permanent paralysis. Poliomyelitis, polio is a highly infectious viral disease that largely affects children under 5 years of age. Now, the virus is transmitted person to person, spread mainly through fecal-oral route, or less frequently, by a common vehicle, for example, contaminated food, contaminated water. And basically what it starts off doing first is multiplying in the intestine. And from there, it will move to other parts, particularly of the central nervous system, particularly of the motor neurons. The initial symptoms you will see are fever, fatigue, headache, vomiting, stiffness of the neck, and pain in the limbs. 1 in 200 infections leads to irreversible paralysis, usually in the legs. Among those paralyzed, 5 to 10% die when their breathing muscles become immobilized. Now remember, all of the skeletal muscles are going to be affected here. And one of the key ones is going to be the diaphragm. Now, there is no cure for polio, only treatment to alleviate the symptoms. Heat and physical therapy were used to stimulate the muscles. Antispasmodic drugs were given to relax the muscles. While this can improve mobility, it can't reverse permanent polio paralysis. Now, polio can be prevented through immunization. And what you see here is the routes by which this is occurring here. You have it through the mouth, and what you have this doing is it will reproduce in the gut. It will then get transported over, following along to the spinal cord, where it will disable the motor neurons here and begin to travel upwards toward the brain. You can see also this here. What you have is some of these individuals have multiple crippling deformities, contractures, atrophy, severe scoliosis, equinovarus, etc. Now, if you notice, relative distribution of neuronal lesions in the spinal and bulbar poliomyelitis. So here you have spinal, here you have bulbar, and all of these where the motor horn is are going to be slowly destroyed. This provides you with an idea of the stages of the destruction here, here. Eventually what happens is that as the cell is destroyed, of course, you have viral replication going on. A couple of other things here. These are the common symptoms that you might see: meningitis, flaccid paralysis, otherwise known as floppy limbs, loss of reflexes, paresthesia, tingling feeling in legs, severe muscle aches, and then eventually paralysis. Now, as I said, it was a highly contagious disease. You suffer severe nerve injury. As this starts off in the gut, poliovirus moves into the CNS, causes these various situations: breathing difficulty, irreversible paralysis, death. This is the typical contractures of polio. If you notice that these limbs here have pretty much lost all their muscle mass because there's no contractions anymore. And you do get a little bit of it, but it's more in a frozen state. Now, I want to share with you a little bit of history, because history tells us a little bit about the medicine. We talk about spinal polio, the most common form of paralytic poliomyelitis, okay? Viral infection, a viral invasion of the motor neurons on the anterior horn cells, or the ventral, front gray matter section of it. So, as you can see here, these guys are getting destroyed. These are getting destroyed, okay? And so the viral invasion causes inflammation of the nerve cells, leading to damage or destruction of the motor neuron ganglia. Now, what you see here is something that we don't see or have not seen in a long time. When polio was out, 30s, 40s, 50s, and an individual became paralyzed, they were put into an iron lung. Now, an iron lung is basically a machine that uses negative pressure to allow the individual to breathe. Okay? So if you can imagine your private room and you look down a whole hallway, these would be wards, meaning that they would be very, very large rooms with many, many of these machines. They would be hooked up to electrical outlets, but if the power ever went out, on the back is like a bellows and an armature, and the nurse or attending individuals would pump back and forth to keep the person going, to keep them breathing. The portals you see here are so individuals can turn them, do blood pressure, remove, basically take care of bodily waste, etc. Some of these were able to eventually recover by forming collaterals from the damaged nerves to recover some function. Others did not. There's a video out on YouTube, and I don't remember where it was. But basically, it's one of the last individuals living who's on an iron lung. There's no more manufacturers, and nobody knows how to make the parts. So he has a special relationship with an individual that fixes some of the components if they start to wear down or break down. He knows that if he had lost the power of everything, he would probably die. Unfortunately, some of these individuals did die in the iron lung machines because basically they didn't have the capability to breathe on their own outside. Now, if you notice these little board-like structures, these are mirrors so the person can look up and down and talk to people. Okay, let's move into influenza. Now, flu, is a contagious respiratory illness caused by influenza viruses that infect the nose, throat, and sometimes the lungs. Now, it can cause mild or severe illness and at times can lead to death. The best way to prevent flu is by getting the yearly flu shot. The flu vaccination is based on what are the prevailing flu strains that are out there. So if this is the northern northern part of the world, what you have is they base it on what outbreaks they have in the southern part of the world, and they find those particular strains, culture them up as vaccines, and then begin the process of preparing them. Now, influenza viruses are members of the family Orthomyxoviridae. Now, this family represents enveloped viruses, and the genome of which consists of segmented negative sense single-strand RNA segments. There's actually 8 different segments. They call them cassettes. And they can mix and match if they co-infect at the same time the same cell with another strain of a different strain of influenza viruses. There are 4 genera of this family, A, B, C, and thogotovirus, of which, however, only genera A and B are clinically relevant for humans. And as I said, that 8 genome segments, they're very loosely encapsulated. And so when if let's say there's a duck flu virus and a pig flu virus and they infect a human cell, they can come up with all sorts of different mixes and new strains of virus. The viral symptoms include fever, chills, muscle aches, cough, congestion, runny nose, headaches, and fatigue. The flu is treated primarily with rest and fluid to let the body fight the infection on its own. Over-the-counter anti-inflammatory pain relievers may help with symptoms. An annual vaccine can help prevent the flu and limit its complications. The flu virus will infect the columnar epithelial lining of the respiratory tract and can cause infection in both the upper and lower airways. The typical incubation period is 2 days, with a range of somewhere between 1 and 4 days. Although primary infections in young children is usually symptomatic, overall 50% of influenza infections may be asymptomatic. In other words, some people will have it, but not really have any serious symptoms. Nevertheless, infected persons with few or no signs of illness may shed the virus and therefore be infectious to others. Now, here is what I'm talking about for this virus. Here you have the membrane that encloses everything, and you have two primary proteins that are of concern: hemagglutinin and neuraminidase. So that when you hear someone say, well, it's an H2N4, it's hemagglutinin type 2 and it's neuraminidase type 4. And different situations arise. Now, if you take a look here, what you've got is the bubbling off of this particular virus. They call it budding off from the plasma membrane of an infected cell. Keep in mind that 1, 2, 3, 4, 5, 6, 7, 8, none of these are interconnected, so they can be mixed and matched. Also, the incidence to population antibody levels. Well, let's talk about, if you look on the x-axis here, you have the time in years. If you look at the y here, you're presumed at some high number, especially when you talk about pandemic, endemic, epidemic, down. And at the same time, you've got this wiggly line here, population antibody level to virus. What usually scientists have come to understand is that if you have a serious flu pandemic, it's roughly about 20 years, okay? And when it comes, a lot of the population doesn't have the antibodies prepared for them. Or they may not be of good health, okay? Now, in this case here, you have a diagram. And this is the human cases of swine origin H3N2 influenza in Indiana and Pennsylvania, resulting from existing influenza viruses exchanging genetic material through a process called reassortment. So what happened is this was reported in Indiana and Pennsylvania in September of 2011. It resulted from a reassortment of two different influenza viruses. The diagram shows three influenza viruses exchanging cassettes, that is, chromosome strands, and developing a new influenza strand. Okay, so you can see by the color, they tell you what some of these do. Some of them will tell you information about the hemagglutinin, and others will neuraminidase. Look what happens if you share so many RNA segments. And by the way, RNA segments can also on their own change. This is where we get into the concept of antigenic shift and antigenic drift. Shift is when you make a large genome change. Okay? Drift is when you have, let's say, a point mutation on one of the strands. And so what you have is that even if this particular HA was similar to its parent, it may have picked up a couple of point mutations, and now it has some other properties. One of the things you have to keep in mind is that when you talk about these type of diseases, they will change through a reassortment, and in some cases, through some point mutations. Here's another one. The diagram depicts the origins of H7N9 virus from China and shows how the virus's genes came from other influenza viruses in birds. So in other words, there are a lot of domestic ducks, wild birds, poultry birds, and so they at times were mixing and matching, and you ended up with this particular combination here called H7N9. And now this is directly infectious to human beings. That's why one of the ways you would have an emerging disease like influenza coming is that There is a close association in some countries with the birds. Birds will migrate, will pick up a flu virus, migrate to another part of the world, as many migratory species do, and some of them will then pass on new traits of a bird flu. And it might come in direct contact with humans or maybe further altered by some other contact, whether that is bats or pigs, etc. And then you have a viral strain that is very serious for human beings. Now we're going to move into rotaviruses. This is the genus of double-stranded RNA virus in the family Reoviridae. It's a contagious gastrointestinal infection that causes inflammation of the stomach and intestine. This is where they refer to it as gastroenteritis. The primary mode of transmission is the fecal-oral route, usually through direct contact between people. Because the virus is stable in the environment, transmission can also occur through ingestion of contaminated food or water and contaminated surfaces or objects. So therefore, we're talking about fomites being a possibility. Rotaviruses are the most common cause of diarrheal diseases among infants and young children. Nearly every child in the world is infected with a rotavirus at least once by the age of 5. Rotavirus disease is characterized by vomiting, watery diarrhea for about 3 to 8 days. Fever and abdominal pain are also common. Some of the additional symptoms include loss of appetite and dehydration. The most common symptoms of rotavirus are severe watery diarrhea, vomiting, decreased urination, fever, and abdominal pain. Now, when you have a decreased urination, that is immediately telling you that your fluid is much lower in the body, in the fluid compartments, the extracellular fluid compartment and the intracellular fluid compartment. And this has been brought on by the watery diarrhea, the vomiting. Now, there's no specific treatment other than preventive vaccination. And one vaccine failed. It was out for a bit and caused gastrointestinal problems with the children. But then they have begun to work on another one that's soon going to be approved by the FDA, I believe. Now, oral and intravenous fluid replacement may be necessary. In infants, breastfeeding can help prevent against the infection because in those cases, mom's sharing antibodies to the child. Now, this is the structural insight into the coupling of the virion assembly and the rotavirus replication. So what you have is how it's put together. And this is what it looks like under an EM image. And you have a double-stranded RNA. And what you have here, you'll notice the various proteins on the exterior and the binding receptors. When we talk about rotavirus infection also, there were some clinical studies that were done. And basically, you can see where if an infection occurs here, even before the symptoms start showing up, you have the individual viral shedding. So this is something of importance in places like schools, daycare, places where there are a lot of kids all at the same time, because it may be a few days before they actually show up with the vomiting, the fever, the diarrhea, and in some cases, hospital admission. Okay? And here you see a child heavily emaciated, low birth weight, or use of formula rather than breastfeeding are risk factors for the rotavirus infection in infants. You have this bottle-fed boy showing signs of dehydration from a rotavirus infection. So you can see how a lot of the musculature is lost, etc. Remember that when a child is getting breastfed, they are getting a large number of factors, including IgAs, including those factors that will help to bolster the construction or the finishing of the sealing up of the small intestine, etc. And also, they will be factors that will help defend against viral or bacterial infections. Measles. Now, measles is a childhood infection caused by a virus. It's known also as rubeola. Once quite common, measles can now almost always be prevented with a vaccine. Now, it's characterized by a prodrome of fever, usually as high as 105 degrees, malaise, cough, coryza, and conjunctivitis, the three C's, a pathognomic examina, the Koplik spots, followed by a maculopapular rash. Gotta have your rash. And the measles is an airborne disease that spreads easily from one person to the next through coughs and sneezes of infected people. Now, measles infect the respiratory tract, then spreads throughout the body. The symptoms include a high fever, cough, runny nose, and a rash all over the body. Okay, but the measles symptoms do not appear until 10 to 14 days after exposure. And they include cough, runny nose, inflamed eyes, sore throat, fever, and a red, blotchy skin rash. Now, there is no treatment to get rid of the established measles infection, but over-the-counter fever reducers and vitamin A may help with symptoms. A child who is sick should drink plenty of liquids, get lots of rest, and stay home from school or daycare to prevent spreading the infection. The disease can be prevented by use of the MMR vaccine. That's measles, mumps, and rubella. And you can see here is the measles virus. And you can see the matrix proteins. You can see the genomic RNA. And you have a phosphoproteins that help keep stabilizing. You also have fusion proteins here and hemagglutinin right here. And as this child would show you, and you can see some of the measles right there, the symptoms include dry cough, runny nose, body pain, headache, sore throat, watering, swelling in eyes, discomfort and fatigue, loss of appetite, diarrhea, light sensitivity, inflammation in lymph nodes, and Koplik spots. Now, Koplik spots you see on the tongue. They're sort of like, someone's referred to them as just like, salt grains there. You can see the measles rash throughout here. Okay. Now let's go to mumps. Mumps virus. So the mumps is an illness caused by a virus that usually happens in childhood. Mumps are easily spread by airborne droplets from the upper respiratory tract. Mumps usually involve pain, tenderness, and swelling in one or both of the parotid salivary glands, the cheek and the jaw area. Swelling usually peaks in 1 to 3 days, then subsides during the next week. The swollen tissue pushes the angle of the ear out, up and out. And the swelling worsens. The angle of the jawbone below the ear is no longer visible. Often the jawbone cannot be felt because of the swelling of the parotid. Now, one parotid may swell before the other, and in 25% of patients, only one side swells. Other salivary glands, the submandibular, sublingual, under the floor of the mouth, also may swell, but do less frequency, about maybe 10%. Nonspecific prodromal symptoms may precede the parotitis by several days, including a low-grade fever, which may last 3 to 4 days, myalgia, anorexia, malaise, and headache. Now, the disease usually takes 2 to 3 weeks to appear, and since the introduction of the mumps vaccine, cases of mumps in the United States are uncommon. There is no specific treatment for mumps. People usually recover within 3 to 10 days. Recovery steps to aid the recovery and lessen the symptoms include rest. The disease can be prevented, though, by the MMR vaccine. So here you have this outing of the orifice of a duct. What you also will see is the parotitis. So you really can't see the guy's jaw as this gland is heavily inflamed. When you don't have vaccines, someone who's highly contagious can easily pass to other people. Fever cases of mumps, where the population is not immunized, you're going to have outbreaks. And a systemic viral infection, this is when you have the mumps virus. It can lead to fever and parotitis. Rubella. Now, rubella they used to call it also German measles. Okay. It's caused by the rubella virus, and it is a contagious disease that is caused by a virus. Most people who get rubella usually have a mild illness with symptoms that can include a low-grade fever, sore throat, a rash that starts on the face and spreads to the rest of the body. The disease can spread through direct contact with the saliva or mucus of an infected person, or through the air by respiratory droplets produced from coughing or sneezing. Symptoms often appear 2 to 3 weeks after exposure, and also will include mild fever and headache. Now, it's usually a mild condition that gets better without treatment in 7 to 10 days. Rubella has been declared virtually eliminated in the United States. Parents are advised to vaccinate their children with the MMR vaccine to prevent its reemergence. There is no specific medicine to treat rubella or make the disease go away faster. In many cases, symptoms are mild. And for others, mild symptoms can be managed with bed rest and medicines for fever, such as acetaminophen. Here you see the virus, a diagram of the virus, and you can see how it has these capsid proteins out here that would bind to a cell. And here you have the genomic RNA. Now, what you have here is the child with a rubella rash. You can see it in some areas of the body. There was a severe concern also in 50s and 60s with German measles, and that is the congenital rubella syndrome. What happens is the pregnant mother gets an infection during pregnancy. Now, humans are only known reservoir for the virus. If they get this infection, it can cause miscarriage or serious birth defects in the developing baby. How bad? Well, deafness, cataracts, heart disease, intellectual disability, liver or spleen damage. The mother may have the mild illness, the rash, lymphadenopathy, and low-grade fever. And this virus is easy to spread with coughs and sneezes. The thing is that this virus gets in, and when you start having the neural development and heart development, it is very conceivable that you will have severe heart defects. Um, Tetralogy of Fallot is one. And also, it seems to cause severe problems with the development of the eye. And if it gets into the eye before it closes up with the lens, etc., it can basically cause all sorts of problems, including blindness. Now we're going to go into varicella zoster viral infections, VZV, otherwise known as chickenpox. Now, varicella zoster is a herpes virus that causes chickenpox, a common childhood illness. To help you to understand this, there is a wide range of herpes viruses that cause various disorders and diseases. All right. Now, this particular virus is highly contagious, and if an adult develops chickenpox, the illness may be more severe. After a person has had chickenpox, the varicella zoster virus can remain inactive in the body for many years. A lot of times it happens to go into dormancy in the trigeminal ganglion. This is the ganglion of the trigeminal nerve, which happens to be one of the cranial nerves. We'll get into shingles in a few minutes. But chickenpox can be prevented by a vaccine now. And the treatment usually involves relieving symptoms through high-risk groups that may receive antiviral medications. Now, what if you do have it? You have calamine lotion, a cool bath with added baking soda, uncooked oatmeal or colloidal oatmeal to help relieve some of the itching. Also, the parent should attempt to try to keep the fingernails trimmed short to minimize scratching, to prevent the virus from spreading to others, and to help prevent skin infections. Okay. Now, here you have a child that just got chickenpox. You can see the spots, and they are including in the mouth. Here is an individual who has varicella zoster virus infection, and it's an older adult. You can see the damage that's going into the lungs, etc., and affecting some of the neurons, and of course the common, basically rash. Now, the last one here is a varicella zoster virus infection. It really looks a little bit more what we're really going to move into. You see, this infection is in the ophthalmic branch of the trigeminal nerve. So everything in here that came out from the trigeminal nerve, that is where you're going to have that painful rash called shingles. And so let's talk about shingles. About 1 out of every 3 people in the United States will develop shingles. It's also known as herpes zoster. This is in their lifetime. Anyone who has had chickenpox may develop shingles. It isn't known what reactivates the virus. Shingles can cause a painful rash that appears as a stripe of blisters on the trunk of the body. Now, the pain may persist even after the rash is gone. This is called post-herpetic neuralgia. One of the things to keep in mind is that a lot of times this will follow one of the dermatomes. In other words, one of the pathways, one of the major nerves going around the body. It may not be bilateral, but will be unilateral. Left side, right side, whatever. There are some treatments to include pain relief and antiviral medications such as acyclovir and valcyclovir. A chickenpox vaccine in childhood or a shingles vaccine as an adult can minimize the risk of developing shingles. Now, the treatment, the drugs include acyclovir, famciclovir, and valciclovir. These are all antiviral drugs. Shingles, though, when it is full blast and it is appearing, can cause severe pain. So your healthcare provider may also prescribe capsaicin topical patch, anticonvulsants such as gabapentin, tricyclic antidepressants, numbing agents such as lidocaine in the form of a cream, gel, spray, or skin patch, as well as an injection including corticosteroids and local anesthetics. Here you see this individual that's over on the side. Here this individual is under the arm and through here. This is a rash that will resolve itself within so many days. The problem is that the pain may persist to last at least a month after the rash is healed. And the incidence increases dramatically with age. There is one other group that may be at risk for shingles if they've had previously chickenpox, and that is the immunocompromised or immunocompetent individuals. Compromised. When you have an immunocompetent host, okay, not much of a problem. Acyclovir, if you're 12 years or older, 4,000 milligrams per day in 7 divided doses for 5 to 7 days can be used. With an immunocompromised children or other individuals that are immunocompromised, AIDS, cancer treatment under a lot of cortisol suppressive therapy. Here you have to go with acyclovir, but it may be higher numbers for a greater number of days, as you can see. When we look at herpes zoster virus, here we have the varicella, and these are rare complications for children, for healthy children. Bacterial sepsis, pneumonia, encephalitis, hemorrhagic complications. For the most part, they get the herpes zoster and the control of the primary infection. It comes up to this dorsal ganglia here, and eventually it passes. It goes into latency. But then somehow we've had a failed immune control, and so the virus reactivates. This is the zoster part, and 15% of the elderly patients have the post-herpetic neuralgia. So as you can see, this is following down one line. The complications that can also occur without the rash. Well, unfortunately, angioencephalitis, myelitis, cranial nerve palsies, vasculopathy, gastrointestinal ulcers, pancreatitis, and hepatitis. Most of the time, the zoster, if the person is getting older, and we're talking 60s, 70s, 80s, their immune system is getting weakened. And as a result, there may be a threshold by which creates the conditions that the virus can now go out and create the shingles condition. Now, there's a nice chart here that I thought it would help you. Chickenpox versus measles. With chickenpox, yes, you have a fever, you have a headache, tiredness of fatigue, red spots that appear on the chest, face, and back. You have a decreased appetite, and the spots turn into itchy blisters. But with measles, you definitely have the fever, you have a red blotchy rash that first appears on the forehead and then goes downward. You can have it also where it gets into the eyes, and so you have a red, inflamed eyes. So the sclera is inflamed. You end up with a runny nose, a hacking cough, and a sore throat. You will also see in the mouth pop-like spots inside the mouth. Okay? Now we're moving into hepatitis. First, we have hepatitis A virus. Now, this is an inflammation of the liver that causes mild to severe illness. Hepatitis A virus is transmitted through ingestion of contaminated food and water or through direct contact with an infectious person. Almost everyone recovers fully from hepatitis A with a lifelong immunity. Hepatitis A is preventable by vaccine. It spreads, though, as I said, from contaminated food or water or contact with someone who's infected. And the symptoms include fatigue, nausea, abdominal pain, loss of appetite, low-grade fever. The condition will clear up on its own in 1 to 2 months. Rest and adequate hydration can help. Hepatitis A is a vaccine-preventable disease, but it can be a liver infection where the Hep A virus is involved. Now, this HAV stands for hepatitis A virus. If it's found in the stool and blood of people who are infected, hepatitis A is very contagious. So if it is spread when someone unknowingly ingests the virus, even in microscopic amounts, through close personal contact with an infected person or through eating contaminated food or drink. This occurs even with food handlers if they're not wearing their gloves and they unknowingly have Hep A. Symptoms of Hep A can last up to 2 months, will include, of course, the fatigue, nausea, stomach pain, and jaundice. The treatment for symptoms of Hep A, the doctors usually recommend rest, adequate nutrition, and fluids. Here's a hepatitis A. Basically, what you have is a naked virus, meaning it's just composed of a capsid, your proteins, and then you have a single-stranded RNA nucleus in here. Okay? And you can see this out here. Same thing. So the capsid, single-stranded RNA. But you want to keep in mind too what some of the things that are happening here. If you have hepatitis A, it's going to, of course, act on the liver. And what you're going to have as a major sign is jaundice. So the sclera of the eyes are going to be yellowish. The rest of the body is going to appear yellowish. Most people have to basically take the time for rest. There may be some other symptoms, such as a pale or clay-colored stool, a dark urine. The stool is because of the fact that the infected liver is not producing the sufficient amount of bile. Okay? The person will have abdominal pain, flu-like symptoms, and basically you have to just have the doctor do a blood test for an antibody to the virus. And once that's confirmed, then the individual has to basically keep themselves away from being in contact with food, other materials, etc., to prevent spreading of this disease. If you see here, the basically reported cases per 1,000 population since 2002, we've seen a marked decrease in all groups, okay? Even the Asian Pacific Islander. There's been a few hiccups, but basically we have reported a great reduction. And part of that is because of the reduction of contaminated sources of food and water, as well as the use of the vaccines. Now, if we look here, this is the actual number of Hep A cases submitted to the Centers for Disease Control by states, estimated number of Hep A cases. What happens is estimated cases are determined by multiplying the number of reported cases by a factor that adjusts for the unreported cases. And that depends how many states declared, how many states had not been doing anything. And you can see here, there is quite a few of them that are not reported, anywhere from 40 to 50% in some cases. All right. And that can be difficult because the unreported cases may also mean that these individuals didn't find out till much later on and may have contaminated others. If we look at this, the clinical course of Hep A, you have the infectious Hep A incubation period of 15 to 50 days. The portal of entry, mainly oral, but also parenteral. And you have the pre-icteric phase. In this period of time, you're going to start seeing a fever. You will report abdominal tenderness, have anorexia, nausea, and vomiting. And in the icteric phase, the fever will begin to die down. And usually children versus adults, there's some difference in time. Eventually, the vomiting risks are reduced, and eventually, although later, the abdominal tenderness declines as well. Now, what about Hep B? Hep B is a vaccine-preventable liver infection caused by the hepatitis B virus. Hep B is spread when blood, semen, or other fluids from a person infected with the virus enters the body of someone who is not. Now, one has to keep this in mind. This can happen during sexual contact, sharing of needles, syringes, or other drug injection equipment, or during pregnancy or delivery. Now, not all people newly infected with HBV, that's hepatitis B virus, have symptoms, but those that do, the symptoms can include fatigue, poor appetite, stomach pain, nausea, and jaundice. For many people, hepatitis B is a short-term illness. For others, it can become a long-term chronic infection that can lead to serious, even life-threatening health issues like liver disease or liver cancer. Chronic cases need medication, possibly a liver transplant. Chronic B can be treated with medicines. Care for acute hepatitis B should focus on making the person comfortable. They should eat a healthy diet, drink plenty of liquids to prevent dehydration from vomiting and diarrhea. Also, chronic Hep B infection can be treated with several oral medicines, tenofovir and entecavir. These are antiviral drugs, and they interfere with the viral replication. But as I said at the end, a vaccine is available. This is extremely important. What you see here is a Hep B virus, where it has the E antigen, it has the core antigen. It looks like you have two layers, but you really don't. This is what would be referred to as an enveloped virus. The lipid bilayer here. Okay? You have also surface proteins, and these surface proteins can act as antigens. Also, you're going to have several copies of DNA polymerase, because what you have here is DNA. You need to be able to replicate the genome once it's infected cells. If you look here, you have the hepatitis B infection, basically the sequela. And so if you have recurrent and eventually infections on the liver. You have granulosis formations. You have nonspecific changes here. This is a nodule formation. One of the things that you're missing is the basically the triads, the hexagonal arrangement of the cells. And in some cases, you can see here, you've got fibrosis. So the cells are no longer being repaired and replaced. They're being replaced by fibrous tissue that is not going to yield the necessary functions that hepatic cells do. Okay. And you can see this here. This is the pathology of fulminant hepatitis B infection. You have your gross appearance of the liver. You see this. You're starting to see massive necrosis, infiltration of the lobules and portal areas, and the bile duct proliferation. Okay? Now, at high magnification, the cellular exudate consists chiefly of mononuclear cells and plasma cells. You've lost a complete loss of parenchymal cells. You have here, using a reticular stain, you've got the reticular network still somewhat intact. But the big problem here is you've lost some of the functions because function relates to the structure and structure relates to function. And so you have this, you do a cut of that liver. It's congested with blood. It has a spleen-like appearance. Here, the cut surface of a more nutmeg liver. I think it's just basically because of the color and because the fact is that you don't have any cellular arrangements that you would normally expect. So finally, in the hepatitis B clinical representation, this is what you're looking at. Serum hepatitis B incubation period 40 to 180 days. Portal of entry is either parenteral or sexual. Infectious hep A, its incubation period is 15 to 50 days. Portal of entry, mainly oral, but also parenteral. So what's the big difference? Well, if you look here, you're talking about the pre-ictic phase, and you have a short period, 4 to 7. In the icteric phase, whether it's children or adults, you can see the period where you're going to have the fever eventually die off. Just to help you, you have to understand something, that hepatitis B in the 80s was a big fear. And then later on in the 90s, going into the next 2000s, in some communities, it was a danger because of the fact that people got a lot more cavalier with sexual intercourse and thought, well, I've gotten HIV covered, so I'm fine. But the problem is they didn't realize that also another sexually transmitted infection can be hepatitis B. So let's get to another one here, and this actually goes into the STI area. Human papillomavirus, HPV. It's a viral infection that commonly causes skin or mucous membrane growths, warts. There are more than 100 varieties of human papillomavirus, HPV. Some types of human papillomavirus infections cause warts, and some can cause different types of cancer. Now, human papilloma virus is the most common sexually transmitted infection. Many people with HPV don't develop any symptoms, but can still infect others through sexual contact. Symptoms may include warts on the genitals or surrounding skin. Now, these infections are often transmitted sexually or through skin-to-skin contact. Sometimes you'll see this as symptoms. You'll have genital warps. These are bumps or groups of bumps in the genital area. You will have cervical dysplasia, the presence of abnormal precancerous cells in the cervix. There are now vaccines that can help protect against some strains of HPV. These strains are the most common to cause genital warts or cervical cancer. And if you look at the human papillomavirus, what you have for its genome is DNA. Interestingly enough, it's got a wrapping of histones around it. You also have a capsid protein L2 as well as L1. And so it's a very small virus. Now, the cervical infection, HPV, initially replicates in the basal cell layer of the cervical epithelium. And HPV progeny virions are then released from cells at the mucosal surface. So what you have here, as you can see, this is an examination here of the vaginal lumen. You have the stratified cervical epithelial here. You have the basal layer down there. And of course, the basement membrane, the lamina propria. And so once you start having the virus settle in, infect, and replicate, it's going to continue to replicate and eventually produce more progeny on the surface and then below it. Well, that seems to be it. Week 4. I encourage you to review the lecture PowerPoints. Read all the supplemental articles in Module Week 4. View all videos in Module Week 4. Participate and complete the discussions for Week 4. Now, in some discussion assignments, they are going to require you to review this week's videos or supplemental articles. I strongly encourage you to help you to examine those things because they are going to help you to comprehend the work. Also, there will be a quiz for Week 4. Have a great day.